get going. We'll get started here. We got 9 cases, and I think probably every single one of them could possibly be on the exam at some location. So who wants to give this one a go?
Dr. Cockerell, I can give this one a go. So first thing we see is a very unique looking specimen. The first thing that kind of caught my eye is it looks like a benign process, and maybe looks like some sort of an excision. The first thing that caught my eye was in the very center. You can kind of see this. You kind of see like this almost pseudostratified epithelium, a little ciliated, in that little cavity right there, and I think at the top area as well. And between the two, you see lots of skeletal muscle between the two areas. And you can kind of see, like, I guess, some potential secretions coming out from those areas. And so the first thought was that could this be either, and we don't see much cartilage either. So the first thought could this be a bronchogenic cyst?
Okay, good. So what type of biopsy do you think they took here?
Was it like signal biopsy?
It's probably either that or maybe kind of an enucleation biopsy. So a lot of times when they have these cysts clinically, they present like obviously a dermal nodule, and they say, well, let's just see if we can maybe make a little slice on the top of it, and then see if we can get the thing to kind of shell out. And probably here it didn't shell out quite so easily, I would imagine, because like you said, there's a lot of muscle here. So there is a cyst, but there's actually a lot of muscle tissue as well. So this thing's kind of embedded fairly deeply, and probably what's happening is it's probably almost got it like maybe almost like a sinus tract. It's probably really communicating with deeper structures, because it's pretty uncommon for us to see garden variety cysts sitting down here in the middle of the skeletal muscle like this. So what was this structure here I was pointing out?
Is that cartilage?
Yes, cartilage plus some calcium here, and it hasn't formed bone yet. So putting all this together, I mean, you said bronchogenic cyst, but is there anything else that you might have to kind of confront on a board examination if they showed you something like this?
Maybe other things that are differential could be like a branchial cleft cyst versus like a thyroid
Yeah,
cyst.
good. Yeah, so branchial cleft, and even though this probably is, when we talk about bronchogenic, what do you mean when you say bronchogenic? Why did you say bronchogenic?
I think with branchial cleft cyst, I think you would expect more like lymphoid nodules in the area, and since I didn't really see much of that, and there was like a good amount of skeletal muscle and cartilage, that's why I thought it's more of a bronchogenic cyst.
Well, I think what you said when you described it first was that you thought this was kind of pseudostratified columnar epithelium, which is what you see in the respiratory tract. And so that's why they call it bronchogenic, because it's sort of analogous to the bronchi and the trachea and the tracheobronchial areas. What is present right at the surface here that I'm pointing out right there? It's as high as I can go.
A little cilia?
Yeah, and it's ciliated, which also kind of goes along with bronchogenic cyst, because you do cilia in your respiratory tract. So this probably is a branchial cleft onlaga, and then we know that when you see branchial cleft cysts, they can sometimes be lined by this. They can sometimes have cartilage in them. They can sometimes have lymphoid aggregates in there. They can have lesions that they can look almost like thymus tissue. Because those all come from the different, branchial clefts in the embryo. So I would recommend reviewing that. They might show you something like this on the exam and might expect you to kind of figure it out, and then they might ask you some questions about some kind of genetic abnormality that might be associated with this, like which branchial cleft, is associated with, a thyroglossal duct cyst. That's another thing you can sometimes see is you see thyroid tissue in these things. So you can see all sorts of little embryologic remnants in these branchial cleft lesions like this. So that's, again, something I don't know how many, a lot of questions on this, but the pediatricians love to ask a few questions about things like this, like embryology. So it's probably worth just at least boning up on it before you actually sit down and take the exam if you want to get a freebie. But this is pretty straightforward. I thought it was fairly characteristic of like a bronchogenic cyst and maybe a branchial cleft cyst. So that's good. All right.
I can do this one. So we have a punch. It looks inflammatory to me.
Good.
What kind of catches my eye is, especially more in the upper dermis, is these kind of purple infiltrates. At higher power, they almost look like granulomas. It
What do you
looks
think
like,
the pattern of the inflammation is here when you just look at it at low power?
I would call it granulomatous.
Well, is that really a pattern, granulomatous? We know we talked about the
Yeah.
patterns that say if it's got histiocytes predominating, you say, it's granulomatous. But if you just look at the pattern, what do you see?
S- More like a kind of nodular diffuse dermatitis.
There are, I agree. I think there's some nodules of some inflammation here. There's something going on down here that we'll look at in a moment. But there's also some interstitial inflammation here.
Okay.
And what kind of cells? So you said granulomatous. Do you think these are histiocytes here at low power?
Um, well, I kind of looked at it high power and and I think there were kind of like a mix between neutrophils and EOs when I was,
Good, but at low power, you might say, yeah, some of these maybe they could be histiocytes when you look at it at this power. But then when you go to higher magnification, they look a little bit different. But you can certainly see this is not a lymphocytic infiltrate.
right.
There's not lymphocytes. So that's the value when you're looking at these things. At low power, you make kind of a 30,000-foot diagnosis and say, well, there's certainly any one of the lymphocytic infiltrates. You can exclude that. What about the epidermis?
Um, Looks like at low power, I can see some spongiosis, maybe a
Maybe a
little
little
bit.
bit, but not a lot. It's
Yeah.
fairly normal, isn't it? It's not
Yes.
real normal, pretty normal epidermis. So we think the action is really going on down in the dermis. So I think you're right. And if you go to higher magnification, let's take a look at the cells. And lo and behold, it is pretty interstitial, isn't it?
Yes, it is.
Now there is this other finding here, which is helpful, but probably the most important thing is when you're looking at a dermal interstitial mostly infiltrate, there's a relatively small differential diagnosis for that. So before we look at this, let's look at this and talk about what else can give you this pattern so that when you're faced with it on the board examination, you won't be confused.
Yeah, so I guess you can think of for like interstitial, you could think of things like GA.
Good,
Um,
good. Now you obviously wouldn't think of GA here, right? Because like you said,
right,
neutrophils and eosinophils.
right. You could think of just like interstitial granulomatous dermatitis. You could think of
Think of that, yes. So interstitial histiocytes. What about the fact that they are not histiocytes?
yeah, so you can think of like palisaded neutrophilic
That's getting a little
granulomatous
closer, yeah, because you've got
dermatitis.
mostly neutrophils here. Now you talk about the palisaded neutrophilic. It's really neutrophilic and granulomatous, right? That's usually seen as somebody that's got connective tissue disease, and they have both histiocytes and neutrophils.
Hmm.
Okay,
Um, you could
but there's
think
two other things here.
you could think of things maybe like with all the neutrophils, maybe like cellulitis.
Good, excellent. Cellulitis. And cellulitis, even if it's bacterial cellulitis, can give you eosinophils too. Definitely can give you some eosinophils also, for sure. So that's definitely one you'd want to consider. What
um,
else would you throw in
I
there.
guess you could also think of maybe like different types of like vasculitis, possibly.
Which type of vasculitis in particular gives you an interstitial mostly pattern? Because most leukocytoclastic vasculitis, for example, is around the blood vessels, right? It's not mostly.
Yes. Um, would it be like with like EOs like Shirkstrauss with that?
Yeah, Church-Strauss actually does give you some vasculitis sometimes. Usually, it's usually a larger vessel vasculitis, but doesn't usually have as much of that interstitial infiltrate like we're talking about here. There's one very rare type of vasculitis that we always think about and take a lot of extraneous biopsies looking for it, and it never seems to be. And it's got an interstitial mostly pattern with neutrophils and eosinophils like this. If it's really the disease, it usually has some leukocyte aplasia in there.
Is it EED?
Uh, no, that's more of a nodular
Okay.
trait.
I'm not
But
sure.
urticarial
Okay.
vasculitis. Everybody thinks, about, oh gosh, he's got urticaria that's lasted for longer than 24 hours. Oh my goodness. You know, he's got a couple of, it looks bruising, therefore it has to be urticarial vasculitis. Well, as we all know, it very, very rarely is that. But if you see it, it looks like urticaria. It kind of looks like a florid form of urticaria with more denser infiltrate, and it's got some leukocyte aplasia if you actually do encounter it. And then if you do the immunofluorescence findings, you'll often see the fibrin in the blood vessels and maybe some complement and other immunoreactants if you get it. So if you see urticarial vasculitis can give you an interstitial mostly pattern like this, what other condition can give you an interstitial mostly pattern like this?
Um, another type of vasculitis are you talking about, or
Just urticaria.
just urticaria? Okay.
Urticaria. So that usually gives you an interstitial mostly pattern. So that's usually what it is when everybody says, oh gosh, it's got to be urticarial vasculitis. They biopsy it 99.999 times out of 100. It's just urticaria. But still, you know, it can give you this interstitial mostly pattern. Now, what if this had mostly neutrophils? We've already said cellulitis. What else can give you an interstitial mostly pattern with mostly polys?
I guess with other things with mostly neutrophils, maybe could be like other neutrophilic dermatoses like Sweet syndrome or
Sweets, yeah, but
Behçet's.
sweets it's okay, good. Those are good things to think about, but they don't usually give you mostly interstitial pattern. Sweets is more of a diffuse pattern with papillodermal edema. Behçet's, if you get the pustular changes in that, it's often a suppurative folliculitis that ruptures, and it's one of the rare conditions where you can actually get true lymphocytic vasculitis. But the autoinflammatory diseases, Stills, you know, those kind of conditions, those will give you an interstitial mostly, look kind of like cellulitis, except when you biopsy that. Okay, what's the diagnosis here? You know what the answer is. I had to figure out a way to kind of stretch
Yeah.
your brain.
Mhm.
Why is it the answer that you already know that it is?
Um, I think because you can see the leukocytoclastic debris, you can see the changes to the collagen, that they're more thicker and kind of changing color, more red. So I was thinking that this was palisaded neutrophilic and granulomatous dermatitis.
Well, one problem is there's no histiocytes in it, though.
Okay.
Really neutrophils and eosinophils. And this does kind of look like uh, it's a collagen degeneration, but it's got eos in it. And it
Okay.
almost looks like it's turning red, like it's becoming almost like a little flame, like it's fire.
Okay.
So now what do you think the diagnosis
And now
is?
I think it's Wells.
You have Wells. Okay, good. And what's the other name for Wells?
Um, eosinophilic cellulitis.
Yeah, good. And does this have the overall pattern of cellulitis?
Yes, it
It
does.
does. Yeah, it does. So it's actually a pretty good name. So when you get like a very dense, you know, interstitial mostly pattern with the flame figures, it's got eosinophils in it. That's the most likely diagnosis is Wells. Now, just one final couple of points. Are these pathognomonic of Wells, flame figures? These are flame figures, so look at these and fix them in your brain?
No, I don't think so.
Good, very good. They're not. You can sometimes see them in an insect bite reaction. Anytime there's kind of a lot of eosinophils, you can get flame figures. It's basically thought to be degranulation of the eosinophils, and it interacts with the collagen bundles and kind of causes this focal degeneration of the collagen, and you get some basophilia of the collagen around it too, because there are neutrophils in it as well. So yeah, it's not pathognomonic, but it's a pattern like this. If you're going to get an example of this on the board examination, here you go. This is what they're going to show you. Something looks just like this. Lots of neutrophils, lots of EOs, more EOs than neutrophils, and then the classic flame figures here. So good. Okay, let's go to the next one.
I can take this one.
Okay,
So from low power, it looks almost like inflammatory, like there's a lot of inflammation, almost like in a lichenoid pattern, but it's not all lymphocytes. There's a
Okay.
few lighter cells in there,
good.
kind of mixed in. There also looks like there's a little bit of melanin in the papillary dermis.
Good.
A little bit, there's some like parakeratosis or some crust. So I thought with the melanin, the melanocytes kind of mixed in with the inflammation, I thought this was a halo nevus.
Okay, good. This is a halo nevus. It's a nice example of that. Okay. And let's see look the other side. It's another thing that is helpful is always look at kind of both sides of this. If you ever get two cuts on your slide, make sure you look at both, because one might show features that are more obvious than others. This one doesn't have as much inflammation as the other one here, but you can see the nice nest of melanocytes here. So this is a halo nevus. Now, how can we make this a question on the board examination that might be challenging? What are they going to put in here to kind of help to maybe confuse you?
Sometimes you can confuse this for a melanoma. That's
Confusion with malignant melanoma. Okay. And sometimes when you see halo nevi and you get so much inflammation in here, the cells actually they can sort of get a little bit swollen. There's a mitotic figure there. Does that mean we're going to instantly change the diagnosis to melanoma?
not necessarily.
No, we're not. Use all the criteria. Use one feature and then say, that means it's melanoma. We're not going to just do a prame stain and see a little positivity and say, that means it's melanoma. So people are doing that today, but that's not really appropriate. What else would they maybe put in the differential for the unwary that didn't recognize the nest of melanocytes here? What does the overall sort of shape look like?
Are you saying like the pattern? Like it looks lichenoid.
It does look lichenoid. So they might put lichen planus in there, right?
They could put lichen planus. I think lichen aureus can also look like this.
Possible, yeah. I usually get more extravasated erythrocytes, but yeah, I think that's not a bad thing. They might throw that in there. What about the overall silhouette of this? Let's say you just color this thing totally black, and you saw these little sort of dilated comedone-like ostia here, and the parakeratosis and the papillomatosis. What does that sort of look like at low power?
Like a verruca?
Well, it's more broad as opposed to being kind of more elevated, like warts usually are. Does it look a little like a seborrheic keratosis?
Yeah, it could be like a yeah.
Yeah, they might say irritated seborrheic keratosis. So these are just some things that if I were writing a board question, I wanted to try to fool someone, those would be some of the things I would put in there. And obviously we would expect them to look carefully and see the nests of melanocytes here and notice that there's melanin in here. So it's good that you recognized all that, because it does look a little bit like a seborrheic keratosis at low power. Now, can you see this type of inflammation in the nevus, but it doesn't have a halo clinically?
You could see like a regressing nevus.
Yeah, sometimes we see nevi that have been inflamed or irritated. They don't have any halo at all, but they've got a lot of inflammation in there. This is a halo nevus this time. But sometimes you see this with no halo, and sometimes you see a classic halo and you biopsy it, it's got zero inflammation. So there's often a clinical pathologic discordance between halo and nevus, which is kind of curious. I don't know why that is, but sometimes we notice that. Anything you should be concerned about in a patient that maybe is, say, in their 30s or 40s and pops up with 10 halo nevi?
I'm not sure. Is there like a syndrome or cancer?
Good idea about, I haven't heard of any syndromes, but sometimes patients that have malignant melanoma that undergoes regression will develop an immune reaction and they start getting multiple halo nevi. And so if you see someone that gets that, you want to make sure that you really look at them carefully and make sure that they don't have a melanoma somewhere else that somehow has triggered an inflammatory reaction that's now reacting to their melanocytes in their body. Same thing with vitiligo. Rare, but sometimes it can occur as a consequence of melanoma that induces an immune reaction. So that's not that common, but it's something to at least think about. Okay, that's great.
Hi, can you hear me?
We certainly can. Let's go to
Okay.
the middle one, maybe.
Okay, so for this one, it looks like a shave of what might have been like a little bump on what looks like an acral surface.
Good.
And then the most notable thing was I saw this kind of like epidermal ballooning, balloon degeneration in the epidermis.
Good. Why did you say?
And so I just kind of see these kind of pink, pale, kind of swollen looking cells kind of right in the middle there.
Okay. What kind of inflammatory infiltrate are we looking at here?
On low power, I think it's just lymphocytic.
Good. Yeah, mostly lymphocytes. Mostly lymphocytes. Let's go to higher magnification. And yeah, I mean, that's a beautiful example of ballooning degeneration, isn't it?
It is.
What else did you see here?
I thought I saw maybe some like little inclusions within the cells.
Good. Very good. That's exactly what this little pink structure right there is. Here's another one. These are also altered by this. Okay, so when you see ballooning degeneration, what's the first thing that pops into your mind?
Something viral, like maybe
Good.
like a or for milker's nodule.
Okay. Or what family of diseases are you talking about there when you say orphan milker's nodule?
I think it's like the farmyard, like.
Okay, it is a farmyard situation where that is often, yeah, where that occurs. But what's the overall arching family of diagnoses that you're talking about there, other than just farmyard infections?
Like the type of virus, you mean? Pox
Yeah.
virus?
Pox virus, good. So we're talking about ORF, Milker's nodule. Are there any other pox viruses that you know about that you should put in the differential here?
Monkeypox would be one.
Yeah, Mpox, I guess they've decided to call it instead of monkey. But yes, Mpox. Others that you should think about?
Is orthopox one? That's a
Orthopox.
different.
Well, it's in the
I think
pox
it's
virus family, but what other pox viruses other than say Mpox and ORF and Milker's nodule fall into that category in dermatology that we have to deal with?
Can't remember the rest.
What's the most serious of all these pox viruses infections that change the course of history?
Oh, like smallpox?
Smallpox. Yeah. What's the other name for smallpox?
I don't know what the other name is.
Variola. very
Oh,
old,
very old.
the other name for that. And that reappears in our literature as in mucohaberma disease, pityriasis lichenoides at Verruciformis acuta, which basically means that it looks like smallpox. You get that ulceronodular type of pityriasis lichenoides. It's really, really aggressive, often seen in young individuals. So that can look like smallpox. And there's really two others that we encounter in derm, but what's another one that looks virtually identical to Milker's nodule and ORF? We used to see this a lot back when I was a kid. We don't get it much today, but back when we had those terrorist kind of attacks back in the 2000s, and they were talking about maybe weaponizing smallpox and getting it out of labs in Russia and all this kind of stuff. What's another pox virus that can look just like this? It also changed the course of world history.
Like the bubonic cowpox or the bubonic
Vaccinia. Yeah, kind of like that. Vaccinia, which basically is the smallpox vaccine. Okay, we don't get too many people don't get smallpox vaccines anymore. But back in the day, when they were worried about weaponizing, they were actually recommending that certain people, military and others, would get smallpox vaccines. And in adults, that can sometimes cause a cardiac problem. So, I didn't want to get it again. I had it when I was a kid. Back when we were children, everybody got smallpox vaccine, and they've pretty much eradicated smallpox today. It's no longer present in the wild, but it still is present in laboratories. So those are the major pox viruses. There's one other one that we see that's by far the most common we see in dermatology. What's that one? Way more common than orphan milk. That's a pox virus infection that we see in children. Peds derm.
Mollusca.
Mollusca. Good. So then and again, those are all similar. They're all DNA viruses, double-strand DNA viruses. Don't these kind of look a little like molluscan bodies here?
I guess a little bit.
Yeah, I mean, it's the same idea. So these are all the same family of diseases, and there's actually some other pox viruses, that you should just be aware of also, but those are the major ones. So I'm glad you recognized that this was a ballooning viral vesicular dermatitis. Can you tell the difference histologically between ORF and Milker's nodule?
I cannot.
No, you need an electron microscope, or you need to be a virologist to do that, so no. And the other thing that I would recommend not wasting a lot of energy with is if you read the textbook's description of all the inflammation, everything that goes on, they talk about layering of inflammation, all that kind of stuff. Just forget that. That's just basically different stages of evolution when you get the disease. If you get it early, you may not get as much viral changes. It's when you get a fully developed lesion like this, it's really a beautiful example. And then you get a very dense, usually lymphocytic infiltrate. You can get some spongiosis and some crusting and some polys. Forget all that stuff. That's just the inflammatory reaction to the virus, to the viral infection. Okay, very good.
For this one, so here we have a shave of a papule. It looks neoplastic to me. Looks pretty benign. It's very symmetrical. Has this like collarette of epithelium around it, which also makes me think it's benign. From high power, it looks like there is.
Do you think it's exhibiting here?
Yeah, so there's some fibromucinous stuff, but I think there's also a lot of vessels
Yes.
in it.
Good.
So kind of vascular.
Vascular.
Yeah.
So when you're dealing with vascular lesions, if it's benign, then what do you basically think it is?
Well, it kind of looks like PG.
Yeah, you sort of say they're like an angioma or angiosarcoma, basically.
Right.
Benign is angioma or, reactive vascular proliferations, or it's going to be malignant, like an angiosarcoma, something like that. So here we're certainly dealing with something in the benign category. Now, you said it looks like a granuloma. What's the overall sort of morphology of a pyogenic granule. What do we call this type of morphology right here?
Like with the capillaries,
Yeah, what do you call this type of capillary proliferation?
the like lobular capillary
Good,
proliferation.
yes, lobular capillary proliferation. Very good. That's kind of a reaction pattern that we see in a number of different entities. There's a few other things where you can see lobular capillary proliferation. You know what those are. That's really a pretty sophisticated third-year resident type of question.
I'm not really sure exactly what the differential is for lobular capillary proliferation.
Okay, that's fine. So there's several that you can see. Acroangiodermatitis from stasis change, and in chronic lymphedema, you get lobular capillary proliferation there. Reactive angiomatosis, where you see those kind of ulcerated lesions, often on pendulous breasts of people and often smokers. That's another situation you get lobular capillary proliferation, obviously pyogenic granuloma, where you can see it. Poems syndrome, where you get actually immunoglobulin precipitates inside blood vessels. You get secondary lobular capillary proliferation around that. And then there's one other situation where you can see it. And notice that there are neutrophils in here.
Yeah, there's a lot of neutrophils, which is kind of unusual for PG.
A little bit unusual for a PG, isn't it? Yes,
Mm-hmm.
Good. And if you also look carefully, you can see there's this kind of amorphous, kind of purplish material between the capillaries.
Mhm.
Does that give you a clue?
That kind of leans towards the bacillary angiomatosis. Those are
Yeah. Good.
smudgy pink.
Bacillary angiomatosis. Absolutely is what that is. And so that's another condition where you get lobular capillary proliferation. And then what's the cause of bacillary angiomatosis? What disease? What's the bacilli that causes this?
Bartonella.
Yeah. And so what's the other disease that looks identical to this histologically? It doesn't occur in the United States. It occurs in South and Central America.
Another Bartonella infection. I'm not sure the name.
Bartonellosis.
Oh,
Bartonellosis. And so, when we first described this thing, we looked at this. I was actually one of the first people to look at this thing back in the 1980s and early 1990s. We first of all didn't recognize this was a bacterial infection. We thought it was some kind of a reactive angiomatous process seen in AIDS patients. And later on, we actually were able to identify microorganisms in here. And then later on, they're actually found to be genetically very similar to Bartonella. And it's not actually Bartonella bacilliformis that occurs in Bartonellosis down in South and Central America. It's a different Bartonella that causes this And actually, this is the same organism that causes cat scratch disease. Interestingly, cat scratch, you get suppurative lymphadenitis. This condition, you get these pyogenic granuloma-like lesions, which is really fascinating. Carrion's disease is also another disease that's important historically, because when they were building the Panama Canal, a lot of people died from that over there. When people were going down there trying to work on that, and that's carried by mosquitoes and vectors and things like that. And so they're getting infected when they were building the Panama Canal. A lot of people got really sick from that. Daniel Carrion's the guy that described that. So this is bacillary angiomatosis. If you wanted to do a stain to prove that this is the diagnosis, what stain would you use here?
I know you can do the Wurth and Starry stain.
Yeah, Wurth and Starry stain. It's actually, the organisms are argyrophilic, and so it's highlighted with that. If you do a PAS stain, it can sometimes kind of highlight that amorphous purplish material. I don't think the board examination would show you this and expect you to tell this from a pyogenic granuloma. So even though it does have the neutrophils that are present kind of diffusely inside the lesion, which is a little bit of a clue to the diagnosis, they probably wouldn't do that to you. But they might show you a picture of somebody that's got like 30 lesions on their skin, and then they might show you this and say the best diagnosis is, and they might put PG down there, and you say, no, that's not more likely to be in that situation. There are other manifestations of this process. They can get liver abscesses, they can get bone involvement, it can be systematized. We've even seen CNS involvement with this. So it's a systemic bacterial infection. Good news is it responds very nicely to erythromycin, azithromycin, those kind of drugs, tetracycline. We don't really see as much of it today as we used to because, you know, a lot of these patients, they're not, it's usually people that have very low CD4 counts that they get this, although we have seen it in some competent patients over the years. So it's a good example of it, but basically it's in the family of things that cause that lobular capillary proliferations. So remember that.
Thank you.
Okay, this is a fun one. This is a board type 1-2. They definitely could show you something like this.
I can do this one. It looks like a deep punch of specimen. First thing that kind of catches your eye. So it looks like it looks inflammatory, not quite neoplastic. And the first thing that kind of catches your eye is that there's a lot of this debris and crust at the very center of the lesion at the top near the epi. And the epi seems like it's very extended. It's like the epitheliomatous hyperplasia, because all the keratin sets look somewhat monomorphic.
Okay, good. So this type of process is often misdiagnosed as a neoplasm. That's good that you recognize that wasn't the case. But yeah, when you look at it at low power, you say, wow, this really looks very verrucous. It's got this marked epithelial hyperplasia. And yeah, you did notice that there's some pretty scale crust on the surface. What about down here in the dermis?
All that looks like, I think probably zooming in closer, there seems to be a lot of almost like microabscesses with a lot of histiocytes, I think some mixed cells as well, some mixed inflammation. And then I think in like a scattered few foci, I may have imagined some round appearing lesions that looked almost like with a broad displaying that could have looked like some sort of a fungal process like blasto. So I think some of this inflammation could be like a reaction to some infectious etiology, like a fungus.
Okay, so, but when you look at it at low power, you see all this pseudocarcinoma hyperplasia, you see this suppurative granulomatous inflammatory infiltrate in the dermis. So that really looks like it could very well be an infectious process. Right. Okay, so before you go to the diagnosis, when you see this pattern, what are some of the things you're going to think about at low power before you come in and start looking in these areas?
So you can think of like a fungal process like mycetoma, bacteria like an actinomycetoma. You can think of neoplastic, if we didn't zoom too close, like a squamous cell carcinoma, versus maybe like a.
But you excluded that. But let's say that you've already decided it's not a neoplasm. So you said it's fungal infection. So which fungi can cause this pattern? What are the ones that are the most likely ones that you're going to look at? So you're going to say, I see this is suppurative granulomatous. I think it might be a deep fungal infection. Here's what I'm going to look for. So what are some of the organisms you're going to be looking for that give you this pattern of inflammation?
I can think of like blastochromo.
Blastomycosis. Chromoblastomycosis, good. Those are two that can definitely do it. What else? Histo, less commonly, interestingly enough. It doesn't generally give you as much of the pseudocarcinomatous hyperplasia. It can, usually not. Usually it's almost kind of more like a diffuse infiltrate with cells that you see the organism in the dermis. It almost looks sort of like cellulitis or folliculitis sometimes, and vasculitis even, because those organisms look like nuclear dust. So it's going to be less likely to give you this pattern here. They actually asked us that on the board examination. It might have been on a practice board years ago. They were asking which type of deep fungus tended to cause more of this pattern versus other patterns. What about, would crypto be likely to cause this pattern?
I think it's more discrete. It wouldn't cause something this massive, I would think.
Yeah, usually not. Usually you get this sort of the gelatinous form of crypto. We had lots of pale areas, and that's the capsular material that you see with crypto. It almost looks at low power like a focal mucinosis or something like that when you look at it at low magnification. So here we've got chromo, blasto. What else? can give you this
Just
pattern.
think of like pheohypomycosis.
Pheohypomycosis can do it. I would throw that in there. What if
Those
it
are the
starts on
main
somebody's hand and moves up their arm?
sporotrichosis.
Orofacial, very good. Sporo. What if they're from Mexico or they're from the Arizona?
Oh, coccidio.
Coccidio, yes. What if they're from Brazil or South America?
The paracoccidioides.
Good. Yeah, good. Those can generally tend to give you this pattern. Good. Now, where are you going to look to find the bugs here? Where's the best place to look? I'm floating around here. Where are you going to tell me to stop? Down here or another place? You got
More, I think
minutes
more
to look
down
at
in the abscess areas.
Good. Look here first. Look in the abscesses. That's the most common place that you're going to see them. Okay, I don't know if you actually saw them or not. Were you able to find any?
I thought I was, but I was staring at it for about 10 minutes. I don't know if I imagined two round circles together.
Well, they're not gonna give you one that isn't pretty obvious, which is a good thing. But that's the first place to look. The second place to look is if you see any multinucleated histiocytes. Look inside there. I don't see a whole lot here. This is mostly just kind of suppurative here. But if you see any multinucleated histiocytes, look inside the cytoplasm of those. We'll see if we can find any. And I don't want to waste a lot of our time doing that. But if they're going to give you one of these, you're going to be able to find it pretty easily. They're not going to make it where it's people are going to argue that they weren't there. So I don't really see a lot here, but there probably were some in here. And then the other place to look is in the crusted areas, because they sometimes get transepidermally eliminated. So you'll see like spores sitting up here, like that might be one right there. So those are some things. That's where you look if you want to really find the organism. So that's just the lesson for this case. If you see this pattern, suppurative granulomatous, start thinking about those kind of infectious agents. Make sure you just know the various patterns of inflammation that these things cause. The one that gives you the least organisms is sporo. So we'll see this pattern, looks infectious, we stain it, and we think it's sporo, and cultures are often positive sporo. Atypical mycobacterial infections can give you this pattern also. Less common to get the abscesses, but you can get it in that too. So that would be something else to put in the differential.
Okay, I can do this one.
Okay.
So it looks like we maybe have a punch here. Was trying to figure out where this was located on the body. There was a lot of adnexal structures. We see a lot of follicles and sebaceous glands. There's also some like muscle at the bottom of the specimen, not too much fat there. So I was thinking this is maybe somewhere on the face, possibly like the upper lip of maybe like a woman with all of the follicles, or what didn't look like there's many terminal hairs there.
Good. Yeah, that's good. This is actually the lip. Here's the muscle of the lips. You can imagine you biopsy somebody's lip deep enough, you're going to get into the muscles. This is probably an excisional biopsy, actually. Incisional biopsy.
Yeah, quite broad. So looking at the specimen here, didn't see too much going on in the epidermis. I saw these like aggregates of inflammation. You can see there.
What pattern would you call this?
I would call it maybe nodular.
Good. Yes, nodular. Nodule, 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 nodule. Excellent. Very, very good. Now you said clusters of inflammatory cells. What kind of inflammatory cells?
I'm thinking maybe like histiocytes and lymphocytes.
Good. Very good.
Lymphohistiocytic.
Histiocytes. You can see at low magnification, they're pale. There's some lymphocytes in here, so very good. So given that it's a nodular inflammatory process with histiocytes predominating, what pattern of that do we call this now?
Granulomatous.
Granulomatous. And what subtype of granulomatous inflammation are we looking at here?
would say like sarcoidal, but there's a lot of
Good.
lymphocytes, so I'm sure.
Good. Sarcoidal. Sarcoidal granulomatous inflammation. So you've narrowed the diagnosis down dramatically, just at low magnification. So now they're talking about that. What's the differential diagnosis of sarcoidal granulomatous dermatitis?
So consider like sarcoid.
Sarcoid itself, obviously.
Yep.
Okay.
And then maybe like there's also some dilated blood vessels there, maybe like granulomatous rosacea.
Okay, good. Very good. I agree with both of those so far.
With it being on the lip, I also considered like a granulomatous cheilitis.
Granulomatous chylitis, chylitis granulomatosa. Good.
And then I think I could also consider like Crohn's on this differential.
Crohn's, cutaneous Crohn's. Absolutely, you should consider that. So you've narrowed it. That's pretty much it. Your diagnosis is going to be basically from one of those entities, for sure. And so, given the lip, which one do you favor the most here?
Maybe the granulomatous cheilitis.
Yeah, this is granulomatous chylitis, also known as orofacial granulomatosis. Now, what disease is associated with that? You said Crohn's earlier, which is absolutely correct. If you see this, you're kind of obligated to rule out Crohn's because it could easily involve the lip like this. So you just make sure they don't have any inflammatory bowel disease. You probably ask them if they've got any history of GI problems. I'm not sure you need to jump straight to colonoscopy, but you definitely need to at least ask them about that. What other disease gives you this pattern?
I think with the I think it's Milkerson's Rosenthal's. That's associated with like
Melkerson-Rosenthal, absolutely. What else do you see with Melkerson-Rosenthal besides just the swollen, firm lip?
you get like the facial paralysis.
Yeah, they get the tongue involved. They stick their tongue out, it moves the wrong direction. So yeah, they can get nerve. Yeah, exactly. And then is there anything else that you might think about that could give you this? And these aren't tight granulomas quite as they're pretty epithelioid, more than you might see in. I was going to say syphilis also could give you this, but usually the granulomas of syphilis aren't quite as epithelioid as these. This really would favor Melkerson-Rosenthal, Crohn's, and those sort of things. But you also put in syphilis. And the last thing I would throw in would be some type of reaction to a filler. So everybody gets, injections of things into their lips to, fillers these days. So it could be a filler reaction. If it were going to be sarcoidal like this, it probably wouldn't be hyaluronic acid. And you'd see the hyaluronic acid. Might be I would say like a weird silicone reaction if it were going to be that. So those are just the other things to think about. Good. So that's great. So that's exactly, this is a very good example. The board is going to show you classic, great examples of things. So this would be something that they very well could put on the exam for you to be able to diagnose. So that's good that you're able to do that.
Okay, I can take this one. This one looked like a punch and it looked inflammatory. And the category I put it in was subepidermal vesicular dermatitis.
Good.
And I guess next to further classify it, I looked up the type of cells
Good.
that are present.
Exactly right. Moving right down in the middle of the fairway. Good. What kind of cells are they?
Sorry, what was that?
What kind of cells are they?
Mostly neutrophils and
Good.
some eosinophils.
Good. Any particular pattern to the inflammation?
It's really high in the dermis.
Good. It is high in the dermis. Anything else that you kind of noticed?
The interface.
Well, I'm trying to point out this little sort of thing right here.
Oh, the dermal papilla.
Yeah, there are collections of neutrophils in the dermal papillae, at least in some foci. It's over here, it's even better. So it's it's pretty diffuse also, but you do see some collections there at the tips of some of these dermal papillae. So obviously, what does that favor?
DH.
Good, dermatitis herpetiformis. Now, what's the differential diagnosis here?
You could think of linear IgA.
Linear IgA, bullous dermatosis. That'd probably be the first one I would put in here because there's some EOs. There's a few others though.
Yeah, you could think of bullous lupus,
Bullous lupus erythematosus.
maybe like a
EOs in lupus sometimes, but it's less common. And it's unusual to get the clusters at the tips of dermal papillae with lupus. So that'd be a little less likely.
and then you could also include BP, bullous
And
pemphigoid.
yeah, you can include BP. You're right. Sometimes you get neutrophil, relative prominence of neutrophils in BP. What other condition that looks a lot like BP, though, is more likely to have neutrophils than bullous pemphigoid?
EBA.
Yeah, EBA. EBA is more, if you're going to see like neutrophils and a weird infiltrate, it's more likely to be EBA than it is bullous pemphigoid. So that's exactly right. What's going on here?
I wasn't sure if those were like corp rounds.
Coron. Okay. We got a little French lesson. I guess we should go through pronunciation of some of these French terms, but coroned, it's like it is, Ron, R-O-N. The DS is actually not even pronounced in French, and it means round bodies. And they basically are just acantholytic, somewhat dyskeratotic keratinocytes. These really aren't dyskeratotic, they're just acantholytic. Don't let that throw you off, because anytime you get neutrophils kind of in the epidermis and whatnot, it can actually cause some acantholysis like this. Or this might have even been a localized coincidental papule of Grover's in the patient that's got DH, maybe. But don't let this throw you off. They're not going to do this on the exam, hopefully, but that'd be kind of cruel and unusual punishment if they showed you this and put herpes or something like that. That just wouldn't be fair. But anyway, that just shows you sometimes you'll see some weird things that don't really make sense. Don't let that throw you off when everything else is really screaming the diagnosis for you. So yeah, you're right. This is dermatitis herpetiformis. Now they might show you this and then ask you some other questions about it. So what's the immunofluorescence pattern, for example? Should know that.
The granular IgA.
Tips of the dermal. Yep, of course. What HLE subtypes are associated with it?
B8.
Yep, B8 is the classic one I think that they teach. There may be some others. What circulating autoantibodies can you find in these patients?
The DQ, or is it DQ too?
Isn't it tissue transglutaminase and antigliadin, those kind of things? So yeah, those are some things that you can see. So those are the kind of questions you might get. One other clue, just for diagnostic purposes that can help you maybe in the future. You see this kind of purplish discoloration of the papillary dermal collagen bundles here? That's called basophilia of the collagen. Just like with that basophilia of the collagen, a little bit around that flame figure with the Wells syndrome earlier, whenever you get neutrophils that degranulate around collagen bundles, they sometimes take on this basophilic color to them. So it's almost like the neutrophil granules are staining the collagen bundles in a way so that they actually become more, basophilic. So that's staying with the hematoxylin a little bit more. So that you often see that whenever they're neutrophils. So if you see this pattern, that's often seen with DH. It's not a criteria for diagnosis, but it's often seen with DH. Okay, good, great, very, very good. That's exactly the way that you work through one of those blistering diseases. Last one for the academic world of the third year residents. Last time you'll ever get asked a dermatopathology quiz question here.
Alrighty, I can take this one. So here we have a shave biopsy of a well circumscribed, symmetric neoplasm, so favoring benign neoplasm.
Perfect.
And then just immediately drawn to the very verrucous, acanthotic pattern of the epidermis.
What part of the
And
body?
so was hard to say, you know, definitely ruled out kind of like head and neck area, just given there's no hairs. Didn't look like an acral site. And then just as I got closer to kind of forming my differential, was favoring maybe like in the genital area.
Good. Why that? Why genital here? What am I pointing to right here?
Muscle.
Yes. And there's a lot of it. So if it's in the genital area and there's a lot of smooth muscle like this, what kind of tissue do we call that?
Like anatomically, like scrotal?
Yeah, erectile tissue.
Okay.
Scrotal tissue is erectile tissue.
Right. Okay.
Areola is erectile tissue. So good. That's a clue. It tells you you're possibly in the genital area or something like that, which can help with the diagnosis here.
Definitely. And then in addition to the epidermal processes going on, you see that there's like a stromal component as well, where you have these paler cells, kind of foamy cells.
So before that, though,
Huh?
say if it's in the genital area and it looks like this is low power, what's your first diagnosis?
You think of a Verruciform Xanthoma.
You're gonna think about that first.
I think, or just a regular verruca.
Regular condyloma. Think about that first.
Right.
And they say, okay, well, there's something else going on here. Let's see. You got higher magnification, and yeah, then you see these other things that you noticed.
Mm-hmm. So you
Okay,
see
here it is.
pale, foamy histiocytes here. And then you see that very pink, like perikeratosis or wet keratin there.
Yeah, and this stuff is thought to be maybe some kind of maceration, if you will. When you see these patients clinically, what do they look like?
What was that?
When you see them clinically, what do these things look like?
They're kind of like flat, pink or yellow, warty lesions.
Yeah, they're kind of glistening. They're often they're not really. They're probably oozing a little bit. See how this got this crust in it, and so they look macerated. They look almost like a little red macerated cauliflower.
Mm-hmm. Mm-hmm.
And then you've got this xanthomatous type of inflammation in here. Yeah, now this is called a verruciform xanthoma. Is it really and truly a xanthoma?
No.
Probably not. A lot of people think these things might actually be kind of warty lesions and they get inflamed and irritated, and this kind of stuff comes in secondarily. There's one other scenario in the human body that gives you a very similar phenomenon, but is not actually a verruciform xanthoma. You probably don't know the answer to this one.
Yeah, I'm not sure.
Fox-Fordyce disease. If you see that, you can actually see the same kind of verruciform xanthoma-like change at the side of the epithelium there. So that's why some people think this is some kind of a histiocytic reactive process that may be going on in the setting of epithelial hyperplasia, chronic trauma, and there is some HPV infection in this thing that's associated with it. But anyway, it's a pretty classic situation. They could show you this. It's fair game. It's a pretty simple, straightforward diagnosis. Just make sure when you see something like this and you do look at it at a low magnification, you say, it looks like a condyloma. You don't stop there. So always go down and look between these verrucous areas, and you look for this degenerated pinkish material within the epithelium, the crust, and then you see all these histiocytes and dilated blood vessels between the epithelial aggregations here. So very good. All right, any questions, comments? Hope these sessions were educational for you guys. Just when you get on the board examination, just remember to go through these things in a systematic fashion. Avoid your tendency just to reflexly make a diagnosis, because that's what they bank on, that you're going to just say, they're going to think it's this, they're going to answer this, they're going to miss it because they're not going to go down systematically, and it's really going to be answer B. So make sure that you go through these criteria, work through these things, and if so, you're going to do well on the examination. I don't think anybody is going to have any problem here. All right, well, good luck, and we will see you second and first years next month.
Thank you.